So good morning everybody. In the last class we have discussed the common reasons for this peptic ulcer, the lifestyle changes, what we are having now, the fried food items and the pizzas. Okay, so peptic ulcer was previously the bread and butter of the surgery. Nowadays we are treating peptic ulcers, most of them, more than 90% of them, with medications. Okay. So the drugs used here are the drugs which neutralize this gastric acid, the antacids. We have buffer type, non-buffer type, the drugs which get absorbed systemically and then act, and the drugs which will not be absorbed, which will act on the luminal surface only. Maybe they act as a protective coats. Okay, they can help in formation of the protective coats of this prostaglandins and the mucus of bicarbonate. Here the drugs are the systemic antacids, that is sodium bicarbonate, non-systemic antacids, that is they are not absorbed. Okay, buffer type we have aluminium hydroxide, magnesium trisilicate. Last class we have discussed that aluminium can cause constipation, magnesium can cause diarrhea, MDAC. Okay, so we are combining both these drugs so that we can still have their effect and we are avoided of their side effects. So the trisilicate, MAGALDRATE, the non-buffer type we have magnesium hydroxide, calcium carbonate. This calcium carbonate is told to be calcium supplements, but they on long term they can cause the increase the acidic environment. Okay, so miscellaneous we have the seaweed derivative, that is arginate, samethicone, that is a drug which is an anti-platelet activity. So the drugs we can reduce this gastric acid secretion. You might have already learnt about some of the drugs. Those are the anticholinergic drugs in the previous classes. Okay, those are the propantheline, oxytoluene, all these group of drugs, pyrazine, tilazepine, all these things. But these are not the first line drugs nowadays because of the newer drugs which are more effective. Okay, more effective in that they act particularly on the system of acid production. Okay, they are blocking the various pathways or the various steps in the acid production. First we have this H2 receptor antagonist. You might have learned about the first H1 generation. Okay, those are cyclizine, buclizine, promethazine, cinnarizine, all those group of drugs you might have learned. Okay, these H2 receptor antagonists are the cimetidine, which is a prototype, no longer used. Then we have this ranitidine, isatidine, roxetidine, and the latest one, that is famotidine. Then we have this proton pump inhibitors, the best drugs presently available. Okay, we have omeprazole, pantoprazole, rabeprazole, esomeprazole, and latest is elaprazole. Okay, most of these drugs are having the same, the terms are named similarly. Okay, these are also called as me too drugs. Okay, I'll be telling you more about this me too drugs, what are suicidal inhibitors, all these things. Okay, then we have this anticholinergic drugs, that is what we have already learned. Then prostaglandin analogs. Prostaglandins are the one which form the protective coat around the inner mucosa. Okay, misoprostol and enprostol. Then we have this mucosal protective, sucralfate, colloidal bismuth substrate, ranitidine bismuth substrate, and the ulcer healing drugs we have carbenoxolone, anti-H. pylori drugs. Okay, nowadays the dictum is the word what they follow is no H. pylori, no ulcer. If there is an ulcer, there is a H. pylori. That is the rule which is followed now, based on which the treatments are fruitful. Ranitidine bismuth substrate, all these things are there, clarithromycin, tetracycline, metronidazole. So we started with the cake so that we can induce the first phase of gastric secretion. Okay, after that we thought how this gastric acid secretion is done and how this gastric acid secretion is suppressed by various steps. Okay, the first is for what you saw, there is secretion of the gastric acid. Okay, that is what we have learned in Pavlov's experiment. Okay, so here once we have consumed the food, we have this dietary peptides. Okay, dietary peptides can stimulate the G cells at the antrum and release this gastrin. Okay, what you are seeing, the green ones which are the gastric. Okay, then we have this vagus which is controlling both. Okay, it can increase and decrease. Increase by acting on this gastrin releasing and also suppressing this somatostatin release from the D cells. Okay, both can be done. It can be done vice versa also. Okay, so here once the gastrin is entering here, you have three stimulus here. Okay, one is the acetylcholine receptor. Okay, these are the parietal cells which will secrete this H plus ions. Okay, you can see that with the help of the sodium potassium ATP system, we have this H plus ions in the luminal side. So how this H plus is produced? We have three regulators here. One is the acetylcholine, one is the gastric, and one more is the histamine release from the enterochromatin-like cells. Okay, sorry, enterochromatin-like cells, ECL. Okay, ECL cell. Once it is gastrin is stimulated here, the histamine from the vesicle, it can be released. Okay, once histamine is released, it can act on the histamine receptors on the parietal cells. Then gastrin, then acetylcholine. What happens next? Cyclic AMP production. Okay, so this cyclic AMP production is stimulated by our histamine, and the acetylcholine and the gastrin, they are involved in the production of calcium. Okay, so this calcium influx and activation of the cyclic AMP can activate the sodium potassium ATP system, whereby the potassium is taken in and the hydrogen is sent out. And how we get this chloride ion, we have learnt here. Okay, carbon dioxide, we told, is a highly diffusible gas which will come inside this parietal cell. By diffusion with the available water there, it can form the carbonic acid with the help of carbonic anhydrous. Once it is formed, the H plus ions are thrown out with the help of this sodium potassium ATP system. Bicarbonate ions are exchanged with the in the basal lateral side with the chloride ions. These chloride ions are particularly chloride channel which can be expelled out here. Okay, so this is how the system works. HCl production is there, and we can have the drugs which can block this production. Okay, so we have the mucosal protectives here which can act on the luminal side. Okay, non-buffer type, buffer type, all these things. The anti-H2 antihistamines, they can act at this region, and the omeprazole, ranuprolol, the prototype drugs of this anti-peptic ulcer agent, that is sodium potassium ATP system is blocked. Okay, then we have the antacids. Okay, how this antacid can act. I don't like the people speaking. Okay, only one you have to speak is with me. I am revising so that it will be helpful for you. So mucus, bicarbonate, and prostaglandins. Okay, these are the ones which are having this protective mechanism to protect our GI mucosa. Okay, see the system what is produced by the body is very smart. Okay, if the HCl is produced in the system, what can happen? There can be self-destructive, but it is throwing out, it is forming the acid inside the wall. Okay, and that wall is protected by three layers of mucus, bicarbonate, and prostaglandins. Okay, this is the beauty of the nature. Okay, mucus protected against this barrier HCl, bicarbonate helps in buffer acidic properties of HCl. Then prostaglandins prevent the activation of this proton pump. Okay, antacids do not prevent this overproduction. Okay, they are not involved in any mechanisms where the acid production is taking place. Okay, is it clear? They are only acting as a protective agent. That means their effect can be short term. Okay, that's it. So antacids neutralize the acid once it is in the stomach. So antacids, what they can do, raising the pH from 1.3 to 1.6. That may be sounding as very small, but will suppress the acid secretion. Okay, so raising the gastric pH from 1.3 to 2.3 neutralizes 90% of the gastric acid, and also peptic ulcer formation, because the gastrin is activated at very low pH. Okay, and the pepsin also activated at very low pH. Okay, the conversion of pepsinogen to pepsin, what we discussed. Okay, 3 P's we told. What were the 3 P's? Peptic, pepsin, prostaglandins, and peptic ulcer. Okay, this pepsin and prostaglandin, they are acting against each other, and if one is dominant, you can get the peptic ulcer. If pepsin is dominant, you are getting black. Okay. We have the sodium bicarbonate. Okay. Here it is a highly soluble drug. It has quicker onset of action. Okay. What can be formed? Carbon dioxide can be expelled out. It can cause belching. Okay. That is one of the side effects here. And if the gastric pH is raised above 7.4, okay, for forming the suppressing the, not by suppressing but neutralizing this gastric acid at that particular moment, if it is raised above 7.4, there can be rebound acidity, something like a feedback mechanism for this gastric acid production. That side effect is there. Okay, unreacted alkali can cause metabolic alkalosis. Okay, so this sodium load, we have the sodium bicarbonate. This sodium load can cause hypertension, congestive cardiac failure, all these things are there. Okay. It can lead to urine ulcer, but after long duration. Okay, the non-systemic antacids, okay, buffer type. We have this magnesium salts. Okay, they have commonly laxative effect. That's why we combine them with the aluminium. Okay, so we cannot use it in renal failure. Then we have this aluminum hydroxide, magnesium trisilicate, and MAGALDRATE. They can rise the pH up to 3 to 4. That means there is less chances of rebound acidity, and also we are suppressing the pepsin activity. Okay, so two actions are done here with the help of pH rising to 3 to 4. So they neutralize the gastric HCl and form magnesium chloride. Okay, they can form bicarbonates and magnesium carbonate. This bicarbonate which is formed is not eligible for systemic absorption. That means there is less chance of metabolic alkalosis. Okay, so NaCl formed in the process account for the chloride loss. Okay, that's why we call it as a buffer type. Okay, so they have this constipation effects, aluminum salts, whereby we combine with magnesium. Then we have calcium carbonate and magnesium hydroxide combination. Okay, they have the property. Calcium can cause constipation effect. Okay, most of the time we discuss where we are using this calcium, what are the added side effects we discussed there. Then coming to the samethicone, which is an anti-flagellantic agent. Okay, it is a silicone polymer and a water repellent. Okay, they act by decreasing the surface tension, and they can also be used for blood source. Then we have the sodium alginates. Okay, this is a sodium alginate. It is a hydrophobic colloidal carbohydrate obtained from the seaweed. It is helping in formation of the protective coat over the gastric surface. Oxytazine, it is a popular surface anesthetic which is combined with this samethicone, oxytazine, alginate along with one of the aluminum or magnesium salts. So antacid side effects, we can guess aluminum, constipation, calcium, constipation, magnesium, diarrhea, all these things will be there. Over and that, there can be nausea, abdominal distension, all these side effects can be there. So coming to the H2 blockers, we discussed some of the H1 blockers, why we can combine both H1 blockers and H2 blockers here. Okay, because for need of the complete inhibition of the gastric secretion, gastric acid secretion, we need both H1 and H2 blocker. Okay, most of the time we combine them. It is also for the antihistaminic action. When we use it in urticaria also, we combine both H1 and H2 blocker. Here also we can combine both. Okay, you can add along with it CPM, chlorpheniramine maleate, pheniramine maleate also for the complete inhibition. So it's a highly selective drug. It has no side effects or very minimal side effects. You can remember the side effects of the first generation of the H1 antihistamines. What are the side effects? Sedation, short-term action, frequent dosage is needed, anticholinergic side effects, CNS side effects, all these things will be there with the first generation, but the second generation we have, or the H2 blockers, we have lesser of those side effects. Okay, it is very effective in inhibiting the nocturnal acid secretion, which is dependent on histamine, and less effect on the meal-dependent gastric-mediated HCl secretion. Here, the volume of the pepsin content and intrinsic factor is also decreased. That means there is decreased absorption of this wheat bulk. Okay, so volume is reduced by 60 to 70%. That is helpful in anti-ulcerogenic effect. Okay, so all these drugs are absorbed orally. Most of them have very good oral bioavailability. At least the least you can expect is more than 50%. So bioavailability is up to 80%. Like the first popular drug which we discussed, okay, is the ranitidine. Ranitidine is no longer used due to the hormonal imbalance, gynecomastia and all. So the popular drug is ranitidine 150 mg two times daily, or famotidine 20 mg 2 times daily. Okay, then here absorption is not interfered by the presence of food, but still we prefer the patients to take the drug half an hour before or half an hour after the meals. Okay, so it can cross the placental barrier and reach the milk. That means there is chances of toxicity in the pregnancy, but here it is a safe drug, wide therapeutic model. So it can be used in pregnancy also. Okay, we can use it with starting with first trimester also. So 2/3 of the drug is excreted in bile and urine. Then H2 antagonist we are using it in duodenal ulcer, gastric ulcer, stress ulcer, but along with the anti-H. pylori regimen. GRD, that is gastroesophageal reflux disease, Zollinger-Ellison syndrome, prophylaxis of aspiration pneumonia, and also in urticaria. We discussed why it is used in urticaria. So H2 antagonist side effects overall less than 3%, but with cimetidine we have more side effects due to its enzyme inhibition and also interference with this hormonal imbalance, gynecomastia and impotence in males. Then P450, the drugs which can be given, which can be metabolized by this cytochrome P450, their availability will be increased, starting with warfarin. So H2 antagonists may inhibit the absorption of the drugs that require acidic environment. What are the drugs which may require acidic environment? Last class we told, starting with iron preparations. Okay. So smoking is shown to decrease the effect of H2 blockers, that we can put it as a drug interaction. Okay, it can be used in caution for people with disorientation and elderly people, and we have intravenous preparation of this ranitidine also. So starting with today's class, okay, we are starting with proton pump inhibitors. Okay, so proton pump inhibitors very special for captors are there with this drug. Okay, you need to remember to understand what is happening here. So you saw the slide with the mechanism of gastric acid secretion. We told that here it is inhibiting this proton pump. Okay, you might be knowing that now. Like if H is not there, okay, the hydrogen ion need to be expelled into the gastric lumen, that is not there. The whole sequence will not be helpful. Okay, so what are the reactions just taking place will not be helpful in preventing this gastric acid secretion production. Okay, so here gastric acid production, the primary ion is H plus ion, but if this proton pump is inhibited, there can be no production of this gastric acid. But there are some indications here. The points are they will not be effective immediately. Okay, so today you have started the drug, you may not be able to block most of the proton pumps immediately. At least you need 3 to 4 days. You use the drug for 3 to 4 days, then only most of the proton pumps in the GI mucosa can be inhibited. Okay, so for immediate effect, it is better to go for the ranitidine. But if you need a prolonged effect, you need to go for the proton pump inhibitors. Okay, though there may be intravenous preparations which are given. Okay, there are intravenous preparations of this proton pump inhibitor, but still you may not be able to get the full effect until 3 days. Okay, that's one of the negative points with this. But once the drug has started acting, at least 3 to 4 days, if you stop the drug also, the patient will have the beneficial effects. Here is the drug. All these drugs are the prodrugs. Remember, all these drugs in this group are the prodrugs. What is prodrug? It needed to be converted to active form for its action. Okay, so we have this. These drugs are called as substituted benzimidazoles. Okay, Remember this term. Lansoprazole, omeprazole, rabeprazole, pantoprazole, esomeprazole, and now we have elaprazole also. Okay. Why so many drugs, so many prazoles? Why is it so? It's marketing, it's money factor. Okay. Today you bring lansoprazole under DCGI, reduce the cost. I will start omeprazole. Omeprazole, you bring it under DCGI, reduce the cost. I will produce lansoprazole, then elaprazole. Okay. They will be having another 100 drugs in their bag, so that they can raise the cost. You got it? No? Okay. So this we have discussed in your pharmacovigilance class, how the drug companies produce these drugs. But my personal experience with esomeprazole, Nexpro is the best till now. Okay, you start the drug, any patient with alcoholism or due to use of tobacco, we have a confirmed gastric ulcer. You can start with Nexpro intravenous injection. By the end of third or fourth day, the patient will be better. Okay, so esomeprazole somehow scores better than the rest of the drug, but pantoprazole is the one which is safer among pregnant patients. Okay, it is safer among the in pregnancies. Okay, the mechanism of action here is the parietal cells, they can release the positive hydrogen ions, okay, during the HCl production. This is what is proton pump. Once this proton pump is there, there are some positive ions there. This drug can be protonated, okay, and these are the weak bases. Okay, these are the weak bases, and in the parietal cells there will be slightly acidic environment. Okay, a weak base can be absorbed back into the parietal cells. Okay, this is the effect what we are using to make it get absorbed into the parietal cells. Okay, we have converted them into weak bases. Here in the parietal cells we have the weak acidic environment. So we are trapping what is called as Henderson's-Eisenbach trapping will take place. That means compared to the other cells, more than 1000 times it can be concentrated in this parietal cell. And the active entity what we are telling is about this sulfinamide. Okay, this sulfinamide is the active form of this drug. Okay, it forms a covalent bond. A covalent bond, that means the drug will not be detached from this bonding. Okay, it forms the covalent disulfide bond with sodium potassium ATP system. That means it is a suicide for the drug. Are you getting? There is a covalent bond, okay, and it takes more than 3 to 4 days for the same cells to produce the newer sodium potassium ATP system. That's how it is active for more than 3 to 4 days even after stopping the drug. Okay, that's why we call it as a suicidal inhibitor. And now one more term we call here is a hit and run drugs. Okay, we have so many other drugs like reserpine, ranitidine, MAO inhibitors. Those are called as hit and run drugs. The concept here in hit and run drugs is even the drug biological half-life is less than that time, the drugs will be active for more than 3 to 4 days. Okay, here it is actually a suicide inhibitor, but also a hit and run drug, because the run part what we are using is for the bioavailability. Maybe like 3 to 4 hours the bioavailability is below the therapeutic level. You are getting? Okay, it is out of this bloodstream in the bioavailability form within 4 to 6 hours, but the drug is active for 3 to 4 days. Okay, that's why we have both the terms used for this drug. So this is a irreversible inactivation. So coming to the next part, okay, irreversibly binding to the H plus potential ATP system prevents the movement of the hydrogen ions from the parietal cells into the stomach. There is achlorhydria, gastric secretion is blocked. In order to return to the normal acid secretion, the parietal cells must synthesize this sodium potassium ATPase, which takes 3 to 4 days. Then what is me-too drug? A pharmacological company, for its benefit, that it can be a new drug. Okay, you just change the slide, add one C, add one carbon atom, add one sulfur atom, which does not change the biological activity, but you can change the name as a new drug. Okay, and escape from the DCGI, drug price control also. Okay, so that is the thing. That's how these me too drugs have come into the market. Prodrug, we told that sulfinamide is the active form here, suicidal inhibitor, hit and run drugs. Okay, all this, anyone can come to you as a short course. So this is the summarization here. Okay, we discussed that acetylcholine and gastrin, they can increase the calcium levels which can activate this protein kinase. Okay, here we told that this histamine, okay, this histamine can release this, activate the cyclic AMP which can activate this protein kinase system. All this system we have learned. Okay, the acetylcholine, we have this pyrazine, tilazepine, oxycodone, all these things. Extra antihistamines we have cimetidine, ranitidine, all this group of drugs. Then also we have this prostaglandin analogs. Okay, it is not an inhibitor here, it is an analog, misoprostol. And one more newer drug we have is the gastrin promoting drug, that is proglumide. Okay, we will be learning with that. Then pharmacology of PPI, we have discussed about this. Okay, oral acid resistant formulations are available. Okay, they release the drug in this time in the parietal canaliculus. We have discussed how it can get absorbed. Okay, it irreversibly inactivates the product of